Hello, 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 and welcome to you all. Thank you for watching this program here on blackdoctor.org. I am Ellis Dean, your moderator for tonight's bold conversation about multiple myeloma. Now, you might be asking yourself, what is multiple myeloma? We're going to answer all those questions. We're going to get all into it. We've got we've got two wonderful guests for you this evening that's going to give you all the information that you need to know from the 50,000 foot level down to the personal level. Everything you need to know about multiple myeloma. But before we get to our wonderful guests, there's a couple of things I need for you to do for me. Number one, if you know somebody that needs this information, tag them. Tag them on your page or share this on your page because we want to get this information out to as many people as possible, and we need your help to get that done. Number two, please, 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 if you are a patient right now that is in treatment for multiple myeloma, anything that is said tonight is for informational purposes only. Do not make any alterations to your treatment or your treatment plan without first consulting with your physician. That is most important. You are in that treatment relationship for a reason, and please, please, please keep that going forward. Now, let's get to our fantastic guests. First, we have Mr. Gregory Proctor. He is a multiple myeloma patient and advocate. He's also an author. He's an overall fantastic person, and he's going to give you some great information about multiple myeloma. And then we also have the magnificent Dr. Yvonne Efebera. She is a hematologist, oncologist, a myeloma specialist. She's a medical director in stem cell transplantation at Ohio Health. And she's going to give you all the great information that you need to know about multiple myeloma. So I know you didn't sign on to watch this to see my face, so I'm going to bring them on so you can see their lovely faces. How are y'all doing? What's going on?
Hi, Ellis. Doing good. Doing good.
Oh, very well. Thank you for having us.
Yeah, absolutely.
We're excited to have you here. So first question for you, Dr. Efebera, is really simple. Toss-up question. What is multiple myeloma?
That's a great question. Multiple myeloma is a blood cancer, and it affects the blood and the bones. It is the second most common blood cancer, the first being lymphoma, and the third being leukemia. So it develops in the in the bone marrow. Our bone marrow is that sponge tissue, in the center of our bones. So normally the bone marrow is responsible for producing all the cells that we see when we do our CBC, the red cells, the white cells, and the platelets. And it's like a factory, right? So it's able to pump out all these different types of, cells that help us, to live our daily lives, the white cells and the red cells and the platelets. And so multiple myeloma affect one of those type of white cells called the plasma cells. The plasma cell represent 2% of our white cell. And normally the plasma cells help to fight infection. So they produce a protein called immunoglobulin that help fight infection when we have a cold or other things. Those, proteins, plasma cells proliferate. Well, in multiple myeloma, those plasma cells become abnormal. Just something tells them to just keep reproducing and reproducing abnormally. And so it can crowd the, the entire, bone marrow space and prevent healthy cells, the red cells, the normal healthy cells, and the platelets to work. And so our immune system can stop, working. And left unchecked, these abnormal plasma cells, now called myeloma cells, can cause a lot of, problems. And they can actually attack the bones and release calcium. And patients can get very, very confused. They actually can attack the kidneys, where, patient, the kidney protein production in the kidney is abnormal, and there's a lot of abnormal proteins being secreted from the kidneys, and patients can have a lot of foam in the urine. And patients can actually end up on dialysis as a result of this. But also the anemia, as I mentioned, these myeloma cells can crowd the bone marrow space and affect the production of the normal red cells. And so patients become anemic and can have shortness of breath and become very, very pale. So if left unchecked, this actually can cause a lot of problems, and it affects about 36,000 new patients a year diagnosed. It's not as uncommon as people think, but less common than breast cancer, lung cancer. But it's something that that we see a lot, especially in the African American community.
Well, Doc, you just teed up my next question, because I was about to say we're here on blackdoctor.org. So my number one question is, how does it impact and affect the Black community?
Yes. So multiple myeloma, like prostate cancer, actually affect more Blacks than Caucasian. So multiple myeloma affect Blacks twice as common as Caucasian, and actually males 1.5 times as common as females. And they are diagnosed a little bit at a younger age. The average age usually for multiple myeloma diagnosis is 65, whereas African American is about 60 or below. And this can have an impact, 1 in 5 overall of people living with multiple myeloma is African American. So very important that we are talking about this and preaching about this in the community, because there are many people out there who may have this and not having symptoms like bone pain, and that sometimes is the one of the most common symptoms that can happen. Bone and anemia are the two most common. 70 to 80% of patients will have these symptoms. So not to disregard these things if you're an African American or even any race, but more so in the African American community.
So I see a couple of things that you just said. I want to kind of reiterate that average age is typically 65, but for Black people, it's 60 or younger, right? And so I'm looking at Gregory here, and I know he's not over 60. Okay, unless Black really don't crack like that, but I know he's not over 60. So we already got that established there. The other thing I want to point out to people is that you just said, Doc, is 25%. You said 20%, because you said 1 in 5 people with myeloma are African American, but we're only in about 13% of the population. So that is that ugly word, disproportionately, is disproportionately impacting our community, and that's why we're having this conversation here tonight.
Absolutely.
So Gregory, Doc just talked about the overarching. We talked about 20% and the big numbers and all this stuff in terms of the Black community. How did you find out? How were you diagnosed with multiple myeloma?
Well, Ellis, for me, I was having lower back pain, and it started probably a month, maybe a month and a half before I was physically diagnosed, to where the pain just became so severe and so intense. My wife was traveling, so she was away from home. I was home alone. One morning, I was laying in my bed, and I could not move my lower extremities, which means that my legs from my waist down, I was just paralyzed. And so I realized at that point that something was severely wrong with me and my body, and I needed to get to seek medical physicianal help as quickly as possible. And as I proceeded to do that, the doctor recognized that, yeah, something's going on, but we can't really, diagnose what it is at this point in time. We're going to have to bring you in for more tests. He gave me an anti-inflammatory shot, some steroids, and basically said, okay, we'll see you back here on Monday. Well, Ellis, I came home and the pain just continued to intensify. So between my L5, L6 on my right side upper hip area, I had basically the tumor had kind of protruded through the tissue, and it was across my sciatic nerve. And certainly for me, it was an experience unlike any other pain. I mean, I'm a guy, and certainly I don't go through certain things that other groups go through, particularly as we relate to maybe like birthing the child. But this pain was so severe for me that I couldn't walk. My mobilization was pretty much zero. And I knew that at that point in time for me that something was more severely wrong than just being able to try and figure out how to navigate this through over-the-counter medication.
Well, I appreciate that. And I can empathize with that pain on that sciatic nerve. That's all I have to say about that. Like Forrest Gump said, that's all I have to say about that. So
yeah.
I feel you with that.
So if you don't mind, I mean, for me, just to kind of add a little bit of humor to this, based on what Dr. Efebera said earlier, this was during my 50th birthday. So happy birthday to me, during my 50th birthday.
Wow. Yeah. So again, in people, I think if there's one thing I want people to remember from Gregory's story, and we're going to learn more about Gregory's story, is in that first part, he kept going back to the doctor, right? We have to follow up. We cannot say that they don't know what they're talking about, or that I'm just going to take some pain medicine, it's going to go away. No, go follow up. And if it's not right, keep going back or go to somebody else. But you have to stay diligent about your health. So you're diagnosed now. And so how did you and your caregiver and your doctor determine the right treatment regimen?
Well, I went through a series of multiple doctors before, actually getting to the point of trying to decipher what that treatment plan was going to be. I went to my PCP, from a PCP to my spine management, from a spine management to like multiple series of MRIs, and then to an oncologist, hematologist that basically kind of said, okay, we need to do a BMB, we need to do a PET scan, we need to do all these other things. And at that point in time, the most important thing for my wife and I, dealing with all of the uncertainty, the anxiety, the emotional stress, because here we are, pretty new to the geographical location of where we're living at now. And we just felt like a fish out of water. So by the time we got to the treatment, and this may sound, a little bit strange. I mean, yes, she said you have multiple myeloma, IgA kappa, P17 deletion, which put me at high risk. And that was all kanji to me. I mean, you might as well have been speaking to me in Greek mythology or something. But the one thing that stood out, which was very significant for me, because this all happened on a Friday, so you got 48 hours to kind of think about this before Monday, is she said, I need for you and your wife to get your affairs in order. Now, if that's not significant, if that's not significant, when you got to spend 48 hours thinking about what she just said before you start treatment on the following Monday, I mean, it was an eye opener for myself and my wife. And so the treatment options that we decided to go with was a couple of things. We emphasized, because I have a team of 8 doctors, and Dr. Efebera is probably going, what? 8 doctors? But yeah, I mean, like you said earlier, you have to make sure that these opinions and diagnoses align with your quality of life. And for us, I told all my doctors, I said, I will endure whatever I have to endure, because I went through, chemo and immunotherapy for 5 days a week, 8 hours a day for 3.5 months before we got myself into remission. I emphasized to all of them, I said, I will put up whatever I need to put up with. However, I want my quality of life, which means that you need to pick the best drugs so that I have the minimal, least amount of side effects, because I want my life back when I get to the other side. And so that was the motive and the mission for me. And I said, I'll do whatever I have to do at home, change my diet, change my routine, exercise, do whatever it takes. But at the end of the day, I want my quality of life back. So that's how we chose my treatment of care.
Well, you just answered my next question. Was like, what was the most important factor, right? It's like, what's the most important factor? That's it. You wanted a high quality of life. Well, first you wanted life, Let's
That's
start
right.
there. So, so you already got the cold water splash when she said, get your affairs in order, right? So you got that. You made the first decision. I want life, and I want quality of life. And so, you went through that treatment regimen because those were your goals, and you kept those goals going forward. I definitely appreciate about you. So quality of life was your most important thing. If there's one thing that you can improve about living with multiple myeloma, what would that be?
Wow. To put that in the context of one thing, I mean, there's so many. There's so many being on the patient side of dealing with this, as most people say, it's, kind of a hideous disease. I would have to say, at any point in time, if I had to put one perspective on this, and this is going to be completely out of the box, the way that I think about this is, for me, it's not about the change. It's really about the humbling aspect of the experience. Because ultimately, for me, I lived 50 years of life in a very flourishing, thriving, prosperous life, traveling all the world, working. And here it is, I'm stricken with, at the age of 50, this disease that has really just said, okay, you know what? This was your life, but now the rug is being pulled from underneath you. And guess what, Mr. Proctor? You're going to have to do things differently. You're going to have to think differently. This is a chapter in your life that is going to divert you from what you're accustomed to. However, you got to get on board. And so for me, it was such a humbling experience that, despite all the financial toxicity, everything that I've had to deal with. I mean, I could share with you numbers, but I'd rather not. But it was just overwhelming. The anxiety, the concern. The biggest thing is how you cope with it, because you have to have, some group of people in your life that's going to be your champions. They're going to be your caregivers. They're going to be your prayer takers. They're going to be these individuals that are going to help you weather the storm, because it's like riding a roller coaster. And if there was anything I could change, if you asked me, what could I change? It would be that roller coaster ride, because, man, that is like falling from, the highest point in the world, and you're not stopping.
Look, and I don't know how that change happened. I used to love roller coasters. Now I'm like, I don't want to get on one. I've done my share of the roller coasters, so I can feel you in terms of the life roller coaster. It's even worse, because you went from get your affairs in order to let's fight this. So how did your community wrap their arms around you? Because you talked about your wife. Y'all had to get that decision together, and I know Dr. Efebera, she's shaking her head yes, because she's like, I'm not just treating the patient,
right?
I'm treating that patient's community, his church community, his family, if you've got children, the children, the impact that could have on your life if you are no longer a part of it, no longer here. How did they wrap their arms around you to help you through this process of treatment?
Well, for me, Ellis, I mean, it was certainly a very emotional time in my life. Like I said, I'm an individual. I've got several thousands of contacts in my cell phone, and when we made the public announcement that here it is, I have the disease, as Dr. Efebera had said earlier, folks are kind of unaware about this disease. So, I mean, they were mistaking it for other things. They're like, well, just go get it cut out and so forth and so on. I'm thinking like, hey guys, I can't do that. This is a blood cancer. So for me, the things that happened and how it overall affected my family and friends was, like I said earlier, you're looking at a guy that's thriving, very independent, business savvy, living a life of flourishing. And then all of a sudden, the carpet is pulled from underneath you. So naturally, there was a lot of concern. How people wrapped their arms around me was through my vulnerability. My vulnerability to put my story out on social media. If I could save one person, if I could emphasize the importance of doing the things you need to do, and don't wait until you get to 50 before you go and have your routine checks and all these other variations of things that we tend to neglect. For me, that became the therapy, because I had so many emotions, so much anxiety build up in me, trying to figure out, how can I cope with this? How can I deal with this in going forward? What is that life going to look like on the other side of stem cell transplant and recovery? And so when the community, and when I talk about the community, I'm talking about worldwide, the community, not only from my podcast, but from people I've worked with, as well as family and friends, when they wrapped their arms around me, I felt the prayer of embracement was very uplifting, and it helped me weather the storm, which was, 2.5 some odd plus years of trying to get through this and get on the other side.
So, Dr. Efebera, I'm going to come back to you for this next question. And thank you so much, Gregory, for sharing.
Sure.
That's a really positive story, uplifting. There's some challenging moments, I'm sure. If I ask you about, chemo and all that stuff, there's going to be some challenging moments in there. There's going to be, like you said, a roller coaster. But overall, I'm glad to see you sitting here being able to share that story. Dr. Efebera, do we need additional treatments for multiple myeloma? And if so, why?
Yeah. But just to emphasize what Mr. Proctor was talking about needing several doctors, it is actually, that's why it's called multiple myeloma. It affects the bones, right? It causes can cause cord compression, that weakness you were experiencing in your leg. That's a bunch of plasma cells sitting down, irritating the spinal cord and causing that weakness in your legs. And so sometimes there's the radiation oncology to help release that pressure in the spine. Sometimes there's the interventional radiologist that to stabilize the spine with like cement, called vertebroplasty. And it does affect the kidney. So often we see, 25% of patients will have kidney problem from myeloma, and so they have a kidney doctor. And then of course the the hematologist. And then, the treatment does cause neuropathy, some of the management that we see. And so you see a neurologist. So it takes a team, to treat a patient. So no, I wasn't saying, wow, it's, that's exactly what, the comprehensive management for a patient with multiple myeloma. And so we definitely, thanks to medical advances, patients are living longer. We just published a paper, and other papers, 20 years ago, the chance of a myeloma patient living 10 years was about 20%, 20 to 30%. Now it's about 70%, going on to 80%. Thanks to medical advances, new drugs that have been, studied on clinical trials. Patients are living longer, but African Americans may have made less progress, than other races. And this might be because, African Americans have had, may not have had the same access to the new treatment, that we have, including, time to starting these novel drugs that we have, time to, transplant. So all that is taken into consideration, even though African American tend to have less aggressive, disease, and they will tend to do actually better if they have equal access to the treatment compared to other, to Caucasian. But African Americans are 37% less likely to have a stem cell transplant. In fact, just in the past month, 2 papers have been published in that, one that, we published, and another one by another, colleague. So all on the equity, and access to multiple myeloma treatment, and focusing on African American outcomes compared to races. If equal access are given, if they have the same access to new therapy, the same time to transplant, the same time to receiving their first treatment and the combination treatment, the outcome is actually better compared to to Caucasian. But answering your question, is why do we need more treatment? Multiple myeloma, even though it is very treatable, it is not curable. It is not curable, and patients can have relapse. With doing your initial treatment and transplant and then maintenance, after transplant, because we have shown through trials that, giving a small dose of treatment after transplant, or even patients who are not eligible for transplant, continuing their treatment, can keep the disease in check on average 67 months, longer, 67 months compared to 27 months, years ago without transplant and those novel drugs. So, but still, 50% of patients will relapse within that time, and 50% will keep going. So you need more treatment, more drugs, more trials that will bring new drugs into the community to help those patients who relapse and then who relapse after that. So we've had lots of drugs approved in this in the past since 2005, but we need more because patients are going to relapse and relapse. And the clinical trial, that's why clinical trials is so more important. And of note, African Americans are less likely to participate in clinical trials. When you look at the 20% of African Americans who diagnose, the myeloma comprises 20% of African American. Only about 4 to 6% of African Americans are enrolled in clinical trials. Yeah. That is pathetic. And when you enroll in clinical trials, because we all metabolize drugs differently, right? And so what may be good for one race may not be good for another. And the only way to find out is if we participate in clinical trials, so we can perform the test that say, well, this works better. Maybe we need a lower dose. Maybe we need a higher dose for this particular, race. So very important, to get, African Americans, encouraged and get them participated. There are several factors that are involved as to why they're not, being, enrolled in clinical trials.
Well, you said a lot there, Doc. So I'm going to address a couple of things first. Number one, I'm talking strictly to the audience. I'm going to take my glasses off of you. Look here. I know we don't like a lot of people in our business. I'm just going to say that up front. Black folks. You're talking about 8-man teams. And that's just the specialists. When I talk about the nurses and all the people that are going to have to, you're going to have to weather that storm. Because of the damage that multiple myeloma can do to multiple systems in your body. We're going to have to weather that storm, and you're going to have to be okay with that. All right? So Black folks, I know it. I know you don't want it. People in your business, but you're going to have to. If you get multiple myeloma, it's going to be a team that's going to help you get through that. Number two, you said some words there, Doc, clinical trials. And sometimes when we're talking to Black people, we say clinical trials. First thing that comes out is Tuskegee and all this other type of stuff. And there's an apprehension to participate into clinical trials. And so for you, the question is, why are clinical trials important? And what benefit and risk should a patient consider when thinking about participating in a clinical trial?
Yeah. So, clinical trials are really, first of all, when we approach patients for clinical trials, they're trials for every level, newly diagnosed patients, relapse patients, and patients who have relapsed and who have used all the drugs that have been FDA approved, right? So, and there are different phases. There's a phase 1 trial, there's phase 2 and phase 3. So phase 1 is, if a company, sees a drug, studies a drug in the lab and they look at the myeloma cells and it attacks the myeloma cells and shows great progress, then they bring it to phase 1. Phase 1 will be for patients who have used all the drugs that are available and have no other option. So they will be given that drug. Even though it's not FDA approved, it's been shown, that it may have efficacy, but that patient has no other option. And so that drug may help that patient. So that's a phase 1. And if that drug shows promise, that it doesn't have, too high toxicity, and it shows that it may work as a single agent, then phase 2, they enroll more patients and they can combine that medication with existing drugs for patients who have used, like say the first line therapy, but still have some other options. But this drug may actually add benefit to the existing drugs that are available. So, and so that phase 2 study, may help the the doctors and the pharmaceutical company move on to the next phase, where they do a phase 3 study, where they combine this drug with a combination regimen, say in newly diagnosed versus the standard combination regimen. Maybe that drug actually will push that overall response from, say, where it was 80% to probably 90% when you add that new drug to it. And so based on the phase 2 study, the FDA might approve that drug to be used in combination with existing drugs that have been approved. So for clinical trials to be approved actually in any institution, now you have the institutional review board that consists of physicians, nurses, ethicists, lawyers, patients too are on the institutional review board to see if this drug, if this study is good for the patient population, that it's not going to cause more harm than good, because ultimately do no harm is the first rule in the medical field. And these are well vetted, and actually they go through FDA. And I've been principal investigator for many drugs. And believe me, I've been through FDA, and they grill you, and you have to write. It has to be comprehensive. And so all these studies are actually well vetted and approved. And this is the only way we're going to know, we're going to advance the management. The goal is for a cure in myeloma, and we are getting there. It may become a chronic disease, okay? Just like hypertension, where you take, a medication and you keep going. I have patients with me who are 15 years after their transplant and doing their maintenance and doing very, very well. So it may become a chronic disease, but we won't, if we just stop where we are, we won't advance, medicine. Now we have new drugs, the CAR-Ts and the bispecifics that are really improving, the response rate of patients who have used a lot of other, drugs. So very, very, important, for us to continue clinical trials to advance the field and make people feel better. And I think people are getting, more and more. We can talk about the reasons why people don't, it's not just people don't enroll in clinical trials, not just patient side, but there are physician side too, that we discuss about biases and seeing a patient coming in to see you without someone coming with them, and you ultimately develop this bias in your brain, same as referral to transplant. So there's a lot of biases going on, not only on patient side, but physician side and caregivers. So those are things actually that the American Society of Hematology is very passionate about. And we'll be giving a talk about this at the meeting in December.
So a quick question about the phases. You don't get to move from phase 1 to phase 2 or phase 2 to 3 or 3 to 4 if you haven't successfully completed that phase, correct?
Right. So as a patient, you can actually start with the phase 1 if you have to be eligible, right? So if that drug works for you, you actually continue on the drug until your myeloma comes back. And if say you're on a phase 3 study, and the new drug in combination with the existing drugs, shows better than the existing drugs, then the FDA approves that drug and it becomes the standard drug. So just like many of the studies we have done, now that we are showing that we showed that 3 drugs is better than 2 drugs. We did a lot of studies on that.
Right.
Now they're looking at 4 drugs in high-risk patients compared to 3 drugs. So we have those studies. Mm-hmm. And we're looking at maintenance. Maybe now the maintenance standard is 1 drug after, is 1 drug. And maybe, 2 drugs is better than 1 drug. Or maybe just in high-risk patient, 2 drugs may be better than 1 drug. Plus, we're looking at, how deep the response is, called minimal residual disease. Maybe when we check minimal residual, because minimal residual disease can detect 1 cancer cell in 1 million cells. So if you do a bone marrow biopsy, you send it for this minimal residual disease, patients can be in a complete response, but still able to detect 1 cancer cell in 1 million cells. But patients who may be what they call MRD negative, minimal residual disease negative, maybe they may not need to be on maintenance for a long time. Maybe we can stop that. So all those studies are going on. And so very important for every, patient to participate in these trials, because, these medicines cost a lot. These medicines have side effects. If we can find ways of knowing which patient can stop treatment early without affecting the outcome, boy, I will love, if I'm a myeloma patient, I will love that, right? Yeah. So
absolutely.
I think Gregory's co-signing that all day long. And so people, what I want y'all to understand is that we have to go through these trials. We have to go through these trials in order to be able to determine if it's 1 pill versus 2. We have to go through these trials to see the efficacy and all that. And so, so we do have to recognize that. So Doc, how is safety monitored? Because I think that one might be a big question. So I'm trying to ask the questions that people watching us here might have, and that question of safety. It's like, am I going to be safe if I participate in this clinical trial? How is safety monitored and maintained throughout the trial?
Well, thank you for asking that. In fact, patients on clinical trial are actually followed more closely than patients not on clinical trial. Because 1, the FDA requires that, and because the company that sponsors they're producing the drug want their drug to be approved, and so they have to monitor the patients. And then we have research coordinators and the physicians who see these patients. Obviously, we're the ones taking care of the patients, and we every time the patient comes for treatment, we ask them, how are you feeling? What new symptoms are you having? Are you tolerating things? And then we write it up, actually, and it gets passed on and it gets reported. So if, say, the centers that are participating in that trial are reporting, a lot of similar symptoms, then the FDA, there's a DSMB board. It's called the disease board that actually meets. They consist of individual physicians and other monitors. So the monitoring, that doesn't include the people from the pharmaceutical company, doesn't include people from the our institution. So these are members that are selected from all over the country that form a board, that review all the side effects that come in. And if they see a particular side effect toxicity that's coming in, that's been reported more, they put a hold on the study. They will put a hold so that they can investigate more. Sometimes during the course of the study, we can do amendments, say to lower the dose or increase the frequency, reduce the frequency of the drug that is being given. So they get monitored very, very closely. So that is not a problem at all.
That is great. I just want to clarify one thing, that I don't want anybody to be, have the wrong information. So as a patient, you can start at any phase. You don't have to start at phase 1. right? You can start it because phase 1 is going to have a smaller group anyway. You don't have to start at phase 1. You can start at any phase. And yes, in recent years, they have some pharmaceutical companies have had times where they've combined phases, where they had phases run simultaneously. So I don't want to confuse anybody and thinking of that. So yes, as a patient, you can start in phase 3, right? You can start in phase 2. It doesn't matter. And there can be some combinations. The question,
it depends on the state of your disease. So we have trials for newly diagnosed patients. Say a patient is newly diagnosed, and we're looking at 3 drug versus 4 drug. So that patient, because now the standard is like 3 drug, okay, for newly diagnosed. But we also have drug that's 4 drug, and so there may be a trial that looks at that, and maybe a dose reduction, and then transplant, 1 transplant versus 2 transplant, maintenance, 1 maintenance versus 0 no maintenance. So there's no placebo, 1 maintenance versus 2 maintenance. So no placebo in this maintenance, because the standard has been established.
right?
Initial treatment, transplant, maintenance, if you're eligible, or if you're not eligible for transplant in some patients, because about 60% of myeloma patients are not eligible. Either they're too frail, age is not a limiting factor. I've had 80-year-old go through transplant, 81. So age is not a limiting factor. It's your frailty and other problems that you may have.
Mm-hmm.
So, but if you're not eligible for transplant, you continue the treatment. And as you do more cycles, the dose can be reduced, and you go on to maintenance after, say, 8 cycles or 12 cycles, which would be like 8 months or 12 months. Mm-hmm. So at every stage, there is a clinical trial that will benefit you and help, the myeloma community, answer some questions that will benefit, all of us in the long run.
I'm going to say something here. Like, I would love to be one of your patients, because I think the energy that you're coming, the love and the passion I see coming through this screen, I'm like, yes, she is going to make sure that her patients are well taken care of. And so I do appreciate that, because I see, like, you got like you start talking about clinical trials, the excitement level, like this is the next level, right? So in that line of patient safety, right? A patient enters a clinical trial. Can they stop at any time, or once they're in, they're in? Is it like, it's not a gang or anything like that? They can stop at any time, right?
Absolutely. Patients can say, I don't want to be on clinical trial. In fact, the physician can decide, say, this is not working well for you. You need to get off the trial. And so it can go both ways. And patients are not tied. If they sign the consent, they can stop at any time and say, I do not want to participate anytime. And then you and your doctor can decide what will be the next treatment for you. Absolutely.
So when we're talking about treatments and medications and all the other stuff, there's the C word, and that's cost, right? And so I'm hearing all that, and I'm saying, this must cost a lot. Like, these clinical trials must cost. I can't afford it. This is a borrowed jacket. I don't own this jacket. So just, in all seriousness, is there any type of support for patients that are participating in clinical trials that can help offset some of those costs that might be associated with it?
Yes, absolutely. So in fact, patients who participate in clinical trials, say if we're using, a study drug, that drug is provided for free, because that drug is not yet FDA approved. So the company, whoever the sponsor is, provides the drug for free. And sometimes with drugs that are FDA approved, the company can provide that drug for free too. All depends. And they do have a lot of support, because now we're looking more at chemo pills. A lot of the drugs, not only in multiple myeloma, but other cancers, are pills, because it's easier for patients. They can, stay home and pop a pill, and it's good. But the chemo pills are more expensive somehow, because the insurance company usually have a deal with the hospital or the center, right? So they only give you a certain amount for the IV or the medications that you get by shot. And so, they just provide that amount to the institution or the hospital, and we give those patients. But the pill, it comes from a third party, like a third. So the copay can be very, very high, but thanks to funds and grant, like the Leukemia Lymphoma Society and other myeloma, Multiple Myeloma Research Foundation and other companies, there are grants that can help patients with those copay, because copays can be high. I've had patients like copay 2,500, 3,000. But we have social workers and nurse navigators that help fill those forms for patients. That, over 95% of my patients will have a grant. That even a physician can have a grant, because these things cost a lot. They can, those grants can pay for those copay. So many patients will actually have maybe several dollars of copay that can be affordable, for many. So I'm really, really excited about the support that we have. Having said that, there are many centers, community centers, that may not have the support that bigger centers have. And so that's something that needs to be revisited, and we're talking to the among committees for myeloma, and with other and with other pharmaceuticals, and advocate to have clinical trials in these communities where they can help patients, and provide the social work support that is needed. Because in the big institutions, we can have those, but the community, that's where the issue is. And I get patients who say, I can't get my medication. And then they come to me and we fill out forms for them, and boom, they get it, And they've been out of medications for like 4 months. And so we're able to do that because we have the support, and small communities do not. So that is the big issue. There's such a discrepancy between the community and then the bigger institutions.
Well, I do have a site that folks can go to if they want to learn more about support that they can receive. So I put it on screen there. It's BMS Study Connect. So you have to put 2 S's back to back. So that's BMS and then the full word studyconnect.com. They can go there and get some more information. They've got FAQs there available for people. So if you have some more questions about the support that you can get, so don't use that as an excuse, folks. Go to the site, find out what you can find out. She mentioned LLS, a Leukemia Lymphoma Society. There is support available for you out there. Just a little work, and we got this great thing called the internet that you can find all the information you need about that. And this is one of the sites you can go to. That's bmsstudyconnect.com. Question for you. I'm going to shift back to you, Gregory. That's a great information. Dr. Yvette, I promise you that the energy, I love it. So, Gregory, what concerns do you have about participating in a clinical trial?
I think first and foremost is the unknown. As Doc has said, the drug has not been FDA approved. In a lot of cases, folks tend to feel kind of like the Tuskegee, event where, you may feel like a guinea pig, but in the same aspect, it's kind of a double-edged sword. I mean, we all have to try to figure out what we can do with our part to try to move forth and advance, drug advancement. Like in my case, I'm on a 3-drug regimen right now, and I'm still on my first line of treatment that I was on when I achieved remission, and I continue to maintain that treatment going forward. And one of my drugs is fairly recent. It's only been around for maybe 10 years or less, but it's combined with a much older drug. So it's kind of as Doc had said earlier, it's kind of a combination, a trifecta approach to try to keep the patients healthy and keep the patients moving forward. But, I think for me, based on the fact that I know I'm high risk, I do live with the sensation that what if, what if it comes back? And for me, I know, and I hope and pray that as I continue to move forward, the drug advancements continue to improve. So if I have to go on a trial, or if I have to do CAR T, or I have to go and do whatever, I'm prepared to do it, because at the end of the day, for me, it's about living, and, a lot of times we don't want to take that for granted, regardless of what challenges or adversity that you're faced with in life. And that was the same mindset I had when I was told that I was diagnosed, and it's the same mindset I'm going to have now. But as long as my first line of treatment is moving forward and, getting the results that are keeping me MRD negative and keeping me stable. And of course, there's a lot that goes behind that. It's not just the drugs. It's about what I'm doing at home, and diet and eating and exercising and all those different things. But it's important, to know that there's other options. And I think, if I have to get to that point in my life, if a trial is required, then so be it. Because like I said, I want to live.
We all do. We all do. So thank you for that. So last question, as we're wrapping up here, having this bold conversation about multiple myeloma with Dr. Yvonne Efebera and Mr. Gregory Proctor. I'm gonna ask this last question to you, Dr. Efebera. What's the one thing that you want people, if they don't remember anything, because you gave a lot of great information tonight, if there's a one thing that you want them to remember from this conversation, what is that thing?
Well, this is something that we haven't discussed. Be an advocate for yourself. Mm-hmm. Be an advocate for yourself. You may go to one doctor and you don't like what it's okay to to get a second opinion. In fact, I encourage my patients, any physician that gets upset when a patient says they're going to seek another opinion, you never go back to them. Don't go back to them. Mm-hmm. You should encourage a second opinion. In fact, I tell my patients, I will refer you to another physician that does myeloma just like me, so you can go get a second opinion if you want to. So, and bring someone with you. It's overwhelming. You may not understand everything that a patient, the doctor is saying. So very important that you bring someone with you to have a second ear and understand what's going on, because the first time it can be, very, very overwhelming. And, one of the things that we haven't brought up is that there's a lack of diversity physicians in myeloma. And so patients may not feel at ease when they don't see someone that looks like them as part of their treating team. That's also one of the talks that's going to be at the American Society of Hematology this December. We, presenting a patient and, from personal experience, patients not feeling, that they're getting the best treatment because they don't see anyone, and they come and see me and they see that I look like them, and boom, they go through everything, compliant. And then I get result that they were not compliant before, but then they come see me and they're compliant because they feel comfortable with the team that takes care of them. So be an advocate. Okay to seek a second opinion, but don't wait too long because this can affect you if you wait too long. Yeah.
Well, I got a reason. I know they're compliant with you, Dr. Efebera. You don't have to tell me that. I know that. If I know anything from this conversation, your patients are compliant with your treatment plans. So, Gregory, same question to you. What's the one thing you want people to walk away with from this conversation?
Well, Doc really stole my, because I'm a pro component of avocation, 100%. But since that's already been discussed, I'm going to go and pivot to the two other things that should be at the top of your list. The second one that's very important is you got to educate yourself. You're dealing with a disease that is tumultuous in the overall aspect of how it impacts everybody differently. And I tend to forget how many different types of multiple myeloma there are, but certainly you need to educate yourself, because your disease is going to be different than, your friends or whomever else's disease that's going through the same process with you, because drug regimens and treatments that we've talked about earlier on, they're all going to work differently. So you need to educate yourself. And one most important thing about educating yourself is knowing your labs, because to me, and I don't want Doc to reach through the screen on this, to me, I view doctors as navigators. And I always have to come into my consultation prepared, knowing what my trends are, knowing what I've eaten, knowing, what I want to discuss ahead of time, whether I've had enough water, hadn't had enough water, whether this is high or that's low. These things, people, we have to be on top of as a part of our overall self-education or avocation, is to ensure that we get the successful outcome that we need. And the last point that I always have to say is never lose hope. Don't ever give up, because the fight is going to be a fight. It's going to be a marathon. It's going to be an ultra marathon. It's going to be whatever you can imagine in the worst context possible. But you've got to have hope. You've got to have that inspiration. You've got to have that desire and that willingness to know that regardless of what you've got to go through, you're going to see the other side. And that's all I've got to say, my friend.
I wish you had a mic so you could drop it.
Yeah.
I want to thank you both for being on this panel and giving us this time. I want to thank the audience for staying with us and watching this program. A couple of things, if I could say anything, is understanding that multiple myeloma, as we said at the top of this program, disproportionately impacts Black people. And we are not fully represented in the clinical trials. And so if I can give my one thing I want people to remember is this: when we have a disease state that we're disproportionately impacted by, we have to be disproportionately represented in those clinical trials. Mm-hmm. And that means you and your family members getting involved and making a stand, because, as I say, involvement improves outcomes. So again, thank you all for joining us this evening, and we will see you next time here on blackdoctor.org.
Thank you.
Thank you.